So much for that introduction, and thank you so much for welcoming me here in Chongqing. It's really been an honor to be here. So again, my name is Shayan Moosa. I'm a neurosurgeon at the University of Virginia. I'm also a representative of the Focus Ultrasound Foundation today. I use both high-intensity and low-intensity focus ultrasound to treat brain disorders. Today we'll take a bit of a detour for this talk, and we'll talk about clinical applications of focus ultrasound in the brain. So as everyone here knows, we can use a diagnostic ultrasound probe to send out sound waves, and we can look at the reflection of those sound waves and create an image for diagnosis. But if we use the curved transducer or a phased array, we can collect all of that ultrasound energy to a single area, and using the mechanical or thermal effects, we can treat areas of the body. And this can be used to treat areas of the brain. Now, this idea of treating the brain using focus ultrasound is not a new one. The Fry brothers, William and Francis Fry, who were American physicists, they studied focus ultrasound, and they actually teamed up with neurosurgeons to treat patients with Parkinson's disease. And they were actually able to improve their motor symptoms. The caveat to this is that they needed the neurosurgeon to perform a craniotomy. So in order to transmit that ultrasound energy, they had to remove a portion of the skull to do that. And as you can imagine, that wasn't very popular at the time. Fast forward 40 years from then, we've then had significant improvements in technology that have made transcranial focus ultrasound both safe and feasible. So in the 1990s, there were improvements in MRI technology, including MR thermography, which allows us to pinpoint areas of the brain that are treated and see the heating in real time. In addition, there's been improvements in phased array technology, where we're able to transmit ultrasound safely through the skull and effectively. And over the next 2 decades, there have been improvements in technology and studies that have shown that we can use this focus ultrasound to open the blood-brain barrier and to also perform thermal or ablative treatments for patients with essential tremor, other movement disorders, chronic pain, neurodegenerative disorders, and psychiatric disorders. And we'll talk all about that. So there are 3 main devices that we've used in clinical trials in the United States, one of which that is FDA approved for treatment of movement disorders is the Exablate Neuro. This is a hemispheric phased array transducer that has 1,024 ultrasound elements. And all of those elements can be focused to a single point in the brain in order to raise the temperature and create a lesion. There's also a low-intensity focus ultrasound version of that can allow us to open the blood-brain barrier. Another device is the Navofus. This is a neuronavigation guided device. So with the Exablate, we're using intraoperative MRI. With the Navofus, we're actually using a computer system with the preoperative MRI that tracks the location of the transducer and tracks the locations of the patient's head. And we can use that to perform ultrasound treatments in a much more effective way using low-intensity ultrasound, or a much more efficient way. Finally, there's another device called the Carthera Sonocloud, which is an implantable device. And this is implanted in the skull, and it's able to emit a beam of ultrasound energy to a particular point in a particular area and open the blood-brain barrier. So using these different ultrasound devices, we can perform different mechanisms for treating the brain. What's been studied the most is thermal ablation, which I'll talk the most about, but we've also used this for targeted drug delivery via blood-brain barrier opening, and there are more investigative uses such as with neuromodulation and histotripsy. So like I said, thermal ablation has been studied the most for the brain, and with this we're focusing ultrasound energy to a single area, heating it up, and once we get above 55 degrees Celsius, we create a necrotic lesion within the brain. And we're able to pinpoint certain areas of the brain, certain pathways that are affected in different disease processes, and we can alter or modulate those processes in order to restore function in patients. So this has been studied in movement disorders such as essential tremor and Parkinson's disease, also chronic pain disorders including neuropathic pain, trigeminal neuralgia, and cancer pain, and also psychiatric disorders including obsessive compulsive disorder and major depressive disorder. So for essential tremor, these patients have tremor that occurs when they go to perform an action. So if you're trying to grab a cup and then bring it to your face, that's when the tremor starts to come out. And it can be very debilitating for these patients. So what we perform are lesions within the brain in an area deep in the brain called the ventral intermediate nucleus of the thalamus. And this is involved along the pathway that's disrupted for patients who have tremor. And you can see after creating the lesion, this is a patient preoperatively. These are their spiral and line drawings, which are very difficult for the patient to perform. But after the procedure, they're much smoother and it's much easier for them to perform. I'm not sure if we can get these videos play, but if we can play the one on the left. So this is before the procedure, so this is the patient. He has a lot of difficulty using a spoon to transfer items from one bowl to another. And I'm sure that can be even more difficult if you're using chopsticks as opposed to the spoon. But after the procedure, if we can play that, you can see it's much smoother. He's able to transfer those items much more easily, able to feed himself, dress himself, and this has a huge effect on his life. And even more amazingly, this is all performed without any incision, without any burr hole in the skull. It's all non-invasive. So at the University of Virginia, we led a randomized, sham-controlled, multi-center trial that was also blinded, looking at a total of 76 patients who underwent this treatment. So 56 of the patients were randomized to the treatment group, and 20 patients were randomized to the sham group. And what we saw was that there was a 50% improvement in tremor scores following the procedure, and this remained durable even a year after the procedure, and subsequent studies that we've performed have shown that this lasts even 5 years beyond the procedure, if not longer. Looking at disability scores, what we see is that there's a 60% improvement in disability following the procedure, and of course with the sham group there was none. So this has been shown to be safe and effective, and following the study, the FDA approved this in the United States for treatment of patients with essential tremor. And that was for unilateral treatments, and just this year it's been approved for bilateral treatments, so treating both sides of the brain. So for Parkinson's disease, we saw a video of a patient with Parkinson's, and with Parkinson's, these patients can actually have many different motor effects. You can have tremor, you can have rigidity, you can have bradykinesia, you can also have something called dyskinesias, which are abnormal movements, and that's what you saw in the video. For patients who have tremor-dominant Parkinson's disease, we can target that same area of the brain that we saw with essential tremor, called the VIN, or ventral intermediate nucleus. And we did another randomized sham-controlled trial at the University of Virginia, which is also blinded. Looking at, this was in 27 patients, 18 underwent the treatment, and 9 had a sham treatment. And if you look at the treated patients in the dark boxes, we can see that there's a 66% improvement in their tremor scores, and only 22% in the sham group. So following the study, the FDA approved this treatment for patients with Parkinson's tremor in 2018. As I mentioned, there are other manifestations of Parkinson's disease, such as bradykinesia or rigidity, and this is best treated via another location in the brain called the subthalamic nucleus. And here you can see we can create a lesion there that's called a subthalamotomy. And we were part of another multi-center randomized sham-controlled trial that was in 40 patients, and this demonstrated in the 27 patients who were treated a above 50% improvement in motor symptoms of Parkinson's disease, and this remained durable even a year after the procedure. And finally, for Parkinson's, we can also target another area of the brain called the globus pallidus internus. That procedure is called a pallidotomy, and that's effective for dyskinesias, or abnormal movements that you can see with Parkinson's disease. And so here you can see that lesion in the brain, in the globus pallidus. And we were part of another multi-center sham-controlled blinded study that looked at 65 patients who were treated with this procedure. And what we saw was that there's a 70% response rate in those patients that, again, remain stable at 12 months, and only 30% in the sham group. So following this procedure, this was FDA approved for Parkinson's dyskinesia in 2021. So these are all the FDA-approved procedures that we have for movement disorders. And there's other research that we're performing at the University of Virginia and other centers in the United States and around the world for treating other disorders such as neuropathic pain. So some of the initial single-center studies were performed in Zurich, and this was for patients with intractable neuropathic pain that was unresponsive to any other sorts of treatments. And they had good results from those studies. So what we did at the University of Virginia is another randomized sham-controlled trial where we performed lesioning for neuropathic pain. So the area we targeted was another part of the thalamus. It's called the central lateral nucleus of the thalamus. And this is involved in pain. It's part of the pain pathway. And by lesioning that part of the pain pathway, theoretically we can improve pain symptoms. And so this is performed on both sides. It's called a bilateral medial thallonotomy. And we're finishing up that clinical study at UVA, and soon we'll be publishing that. But some results from the University of Maryland that have been presented have shown that this can be very effective for trigeminal neuralgia that's intractable to other treatments. We are also performing a phase 1 clinical trial at UVA, University of Virginia, where we're performing what's called a mesencephalotomy. So this is another part of the pain pathway. It's in the midbrain, deep inside the brain. And this is useful for patients who have head and neck cancer pain. These patients, unfortunately, have very few treatments available to them. And by creating a lesion in this area of the brain, we can create numbness where they typically have pain, and it can be very therapeutic for these patients who are suffering in the final months of life. And so we're halfway through this clinical trial, and have had very effective results for that. In the next year or so, we should be publishing those results. And finally, going along with thermoablation, there have also been thermoablative studies for neuropsychiatric disorders, including obsessive compulsive disorder and major depressive disorder. These have been led at the University of Toronto. And for these patients, what they performed are ablations of an area called the anterior limb of the internal capsule. This is involved in those disease processes that cause these psychiatric disorders. And 2 phase 1 clinical trials have been performed at that center, each with 6 patients. With obsessive compulsive disorder, they saw a 66% improvement or response rate. And for the major depressive disorder, there was a 33% response rate for this patient. So much needs to be done in that as far as randomized clinical trials, but there is some impressive results. So that is most of the important clinical trials that have been done for thermal ablation. There are other ways of treating the brain using focused ultrasound, such as with blood-brain barrier opening. And I think this is much better if you want to treat a large area of the brain, because that's easier to do with low-intensity focused ultrasound. So if you want to treat a large tumor or neurodegenerative disease, such as Alzheimer's, this is the way to go. So if we can play the video on the right here. With blood-brain barrier opening, what we're doing is we're administering microbubbles into circulation. And these microbubbles, when they're exposed to ultrasound, they expand and contract. And that's called stable cavitation. And what this does, it disrupts the tight junctions in the blood-brain barrier, and that allows the agent, the therapeutic agent, such as a chemotherapeutic agent, to then exit the vasculature and enter the brain, which typically would be very difficult without opening the blood-brain barrier. So this has been used in neuro-oncology, such as with glioblastoma and cerebral metastases, neurodegenerative disorders such as Alzheimer's and Parkinson's disease, also ALS, and then this has also been used in terms of gene therapy for Parkinson's disease as well. So for neuro-oncology, blood-brain barrier opening has been used in several different clinical trials. In fact, there are over 10 clinical trials going on all around the world using the different devices that I mentioned, as well as different chemotherapeutic agents. And there isn't much published yet, but some of the preliminary results are impressive. One of the preliminary studies that has been published is using that SonoCloud device, which is the implantable ultrasound transducer in the skull. So this was published in 2019. And what the authors did is, in 20 patients with recurrent glioblastoma, they implanted this device, and every month, for 10 months, they opened the blood-brain barrier, and they administered a chemotherapeutic agent. In this case, they used carboplatin. And first off, they showed that this was safe. There was no microhemorrhages or other abnormalities that occurred afterwards. But they also showed that there were effective treatments with this. And in one case where there was a recurrence, it was outside of the field of that device. If you look at their progression-free survival in patients who did have blood-brain barrier disruption compared to none, it was greater than 1 month improvement in progression-free survival, and if you look at overall survival, it was greater than 4 months. So again, this is preliminary work, but there are several clinical trials which should be finishing in the near future, which will show us more data in terms of blood-brain barrier opening. Again, this can also be used for neurodegenerative diseases such as Alzheimer's. There are a couple clinical trials underway for this, but some preliminary work has been published. This is by a Korean group, which was published in 2021. What they showed is that they were able to open large areas of the blood-brain barrier within the frontal lobes. And they showed that this was safe, And using PET scans, they also showed that there was a suggestion of decreased beta amyloid deposition within the brain. And as you might know, in Alzheimer's disease, you have increased beta amyloid deposition, which leads to the neurocognitive deficits. They also saw that there was some mild improvements in the neurocognitive deficits transiently as well. So again, this is preliminary data, but there is some promise to this treatment. And as you can imagine, if we open the blood-brain barrier, we're able to deliver agents to parts of the brain. But we can also sample agents from parts of the brain as well. And this is a concept called liquid biopsy. So if a patient has a brain tumor, we don't know what it is, we often have to place a needle through the brain, which has its risks, in order to sample that tumor. But theoretically, if you can open the blood-brain barrier and sample the blood right afterwards, you can potentially get an idea of what that tumor is, and this would have very minimal risk. So this has been tried by a group in Toronto. They studied this with high-grade glioma. So over there, they're doing a clinical trial for blood-brain barrier opening, followed by temozolomide chemotherapy for patients with high-grade glioma. And what they tried in a sub-study was taking blood from patients right after blood-brain barrier opening, and they looked at cell-free DNA of the tumor. And they saw a large increase, 2 to 3 times increase in that cell-free DNA after opening the blood-brain barrier. So this shows that potentially we can use liquid biopsy safely for patients with deep-seated tumors. An exciting new concept is something called sonodynamic therapy, similar to photodynamic therapy, which you may be familiar with. So in this case, what we're doing is delivering a sonosensitizer. It's a drug that collects within the tumors and metabolized preferentially by the tumor. And that drug is typically safe, but when it's subjected to ultrasound, it undergoes a conformational change that then releases reactive oxygen species and can lead to necrosis of the tumor. And so there are 3 clinical trials underway, 2 in the United States, 1 in Italy. I'm leading one of those in the United States. And hopefully in the next couple of years, we'll see if this is an effective treatment. But some of the preclinical work that's been done has shown that it can be. What has been shown is in a proof of concept study with diffuse intrinsic pontine gliomas, which is a very difficult to treat pediatric tumor. Sonodynamic therapy has been shown to be safe in that case, but what remains to be shown is if it is effective. And an investigational use for ultrasound is something called neuromodulation. So in this case, we use the mechanical effects of ultrasound to change the firing rate of neurons. This has been studied by a Taiwanese group using the Navifus device. These patients that they studied had intracranial electrodes, which we use to see where seizures are coming from. So they're admitted to the hospital, they have these electrodes in the brain, and we see where the seizures are coming from. We map the brain. What they did is they delivered ultrasound energy to the contacts of those electrodes that they were measuring from, and they saw that there was a decrease in firing rate of those electrodes in the treated areas as opposed to the non-treated areas, with a decrease in spectral activity. So potentially ultrasound can be used to modulate the brain, to treat epilepsy or other disorders without actually creating an ablation. There are 2 other methods that are used, something called immunomodulation or radiosensitization. This has been studied preclinically, but there really isn't any human data as of yet, but there are some exciting prospects for this. In this case, what we do is we heat up the tumor, and what this can do is actually induce an immunologic response which can damage the tumor. And the other is called histotrypsy, which is being used for body tumors. It remains to be shown if this can be safely done within the brain, but in this case we're using inertial cavitation, where we're bursting air bubbles or microbubbles in the tumor to break up that tumor. But this also needs to be studied. So I think the future for focused ultrasound is extremely bright. We now have the technology to access parts of the brain that previously weren't accessed non-invasively before. And we have a much better understanding of several of the disease processes as well. So with this improved understanding and improved technology, I think we can treat patients less invasively, safer, and more effectively in the future using focused ultrasound. So with that, I want to thank you for your time. If there's any questions, I'm happy to take them. Otherwise, feel free to email me. Thank you.